Beliefs also reverberate through the cultures of West Africa as promulgated by practices of priests and kings. The fact that the Yoruba word for heart or come is the same as the word for mind already explains how they view the heart. This is reminiscent of the Chinese word for heart, Zen, while and it is also translated as heart mind. When statued by sudden scare, a Yoruba man will exclaim, upcoming Padawagba Ile, meaning my heart return in order to receive blessings. Scientific contributions to our contemporary understanding of the human heart can be traced back to the works of Leonardo da Vinci, Andreas Vesalius, and William Harvey. Hippocrates was the first physician to provide anatomical descriptions of the heart, while Galen expanded this understanding. I will now break down what Hippocrates was saying 2,400 years ago, using real times that you can relate with. Think of the heart as a duplex with 2 rooms downstairs, that is ventricles, and 2 rooms upstairs, atrium. In the olden days, Roman houses had a walk-coming lobby without a roof called atrium, meaning under the sky, open. Ventricle meaning belly. If there was anything like the bottom of your heart, it would be your ventricles. The anatomy of the human heart. The human heart is a 3-layered muscular organ, roughly the size of a closed fist, weighing 250 to 300 grams in females and 300 to 350 grams in males, and located slightly to the left of the center in the chest cavity. The human heart has 4 chambers, just as we have said earlier on. The right atrium receives towards the lungs. The left atrium receives oxygenated blood from the lungs after purification, what we can call purification, through the pulmonary veins. Blood then passes through the mitral valve into the left ventricle. The left ventricle is the strongest chamber, and it pumps oxygenated blood to the entire body through the aorta. The aortic valve prevents backflow of blood into the heart. The physiology of the heart. Very briefly, the heart functions as a double pump that circulates blood through 2 distinct circuits as shown in that figure 1. That is the pulmonary and systemic circuits. The pulmonary circulation, the purpose is to give oxygen to the blood that is returning from the body. The systemic circulation, the purpose is to send this oxygen-rich blood to the body. And just as the domestic pump in our various homes, the domestic pump has 2 parts. The mechanical part that will not work if there's no NEMA. That is, that mechanical part must be energized with electricity. The heart's rhythm is regulated by an electrical conduction system. Again, that's the systemic circulation. There will be a diagram to show, and that is it, the electrical circuit in the heart. The generator of the heart, just like the generator of the house, is known as the sinusoidal node. It generates the electricity that powers the heart. If anything goes wrong with it, of course, by nature, God has designed it. There are some other high-ranking officers in line that can take over. But naturally, it's just a node that generates electricity that powers the heart. Then, further down, the upper yellow, then down is another center called atrioventricular node. Again, this can be likened to a step-down transformer in the municipal power supply. From the transformer, that is from the AV node, we have a bundle of His and Purkinje fibers, which conduct the impulse through our ventricles, causing them to contract. This can be likened, the bundle of His and Purkinje fibers can be likened to the armored cable. If you get back home, look at the transformer in the neighborhood, you see a black, thick wire. That's the armored cable. In the heart, you also have it as a bundle of His. And then the distribution system that takes electricity to your various locations in your homes, we also have that as the Purkinje fibers, the fastest. The heart is the first organ to form during pregnancy. It receives its blood supply through the coronary arteries. And it starts beating like 5 weeks in utero, that is, in the uterus. And it beats like that until death. And that is why we have to guide our hearts jealously. Anything goes wrong and the heart stops, that may mean instant death. For the heart, but before we get to the heart, it then means that the heart starts beating to death. Thus, in a lifespan of 70 years, the normal heart beats for 2.7 billion times, pumping approximately 7,200 liters of blood per day and 2.6 million liters of blood per year. And its anatomy and physiology work together to maintain a continuous rhythmic heartbeat that ensures blood is effectively circulated, supplying tissues with essential nutrients and oxygen. For the heart and the network of blood vessels are intricately and delicately put together. For the heart to serve its role, no efforts should be spared at improving heart health through education, advocacy, and community engagement. No wonder the Holy Bible in Proverbs 4:23 says, you should keep, says, and I quote, keep thy heart with all diligence, for out of it spring the issues of life. From the heart, I would like to speak from my heart. By now, no, I do not mean my anatomical heart as either to describe, but rather the metaphoric one that simply implies sincerity of speech, an experience while in clinicals in medical school that shaped me into a heart doctor was my coffee addiction. There's somebody in this audience who will remember that. I embraced a liking for coffee, which was useful for night drinking right from secondary school. I was so accustomed to coffee that its aroma will get me craving for a sweet. In no time, I developed an unusual awareness of my heartbeat called palpitations. My young medical mind was worried that I had developed a heart problem. So I visited the cardiologist, Professor AYODELE, at the UCH in Ibadan. This was the moment that changed the trajectory of my professional path. Further strokes of serendipity led me to the cardiology unit in my final year of medicine post, and also my house job, all again with Professor Fallash. I came back from NYC in June 1982, hoping to pick a letter of appointment in UCH as previously assured. This did not materialize because of an ongoing embargo on employment. Again, it was Professor Falashe who gave me an introductory letter to Dr. and later Professor N.A. Arapoyi, a cardiologist. The plan was for me to stay in Ilorin for 6 months and then go back to usage. But here I still am, 42 years. It is evident that I was made of the heart, molded for the heart, and now means from the heart. My musings lead us directly to the heart of the matter, communicating the non-communicable heartily. Non-communicable diseases, NCD, are typically non-contagious, non-infectious, and not transferred from person to person. NCDs are responsible for a growing burden globally, causing about 43 million deaths in 2021. Diseases are commonly linked to older populations. However, approximately 18 million NCD-related deaths occur before the age of 70. The impact of NCDs is generally highest in low and middle-income countries, contributing to 73% of global NCD deaths. These diseases have also emerged as a significant public health challenge in Nigeria, contributing to a substantial burden of morbidity and mortality. By accounting for 7 out of 10 worldwide deaths, NCDs are impediments to efforts at reducing national and global health inequalities. 4 diseases have been responsible for not less than 80% of NCD-related mortality, morbidity, and mortality worldwide. These diseases include cardiovascular diseases, cancers, diabetes, and chronic lung diseases. CVDs are the leading cause of NCD-related deaths, with almost 20 million deaths globally in 2021. There is an increase in the prevalence of NCDs due to an epidemiological transition from predominantly infectious diseases to that of chronic non-communicable diseases in most African countries. This is due to increased urbanization, industrialization, adoption of Western lifestyles, and increased life expectancy. Prevalence of NCDs in Nigeria, the WHO estimates that NCDs account for approximately 27% of all deaths in Nigeria. The Nigeria National Demographic and Health Survey reported that the prevalence of hypertension among adults was around 30% in 2018. The prevalence of hypertension in Nigeria increased from 8.6% in 1995 to 32.5% in 2020, representing approximately 4.3 million and 27.5 million individuals, respectively. In tandem with these findings, 34.1% of adult Nigerians in an opportunistic screening, which we call the MMM, the May Month Measurement, it's a project between the International Society of Hypertension and Nigerian Hypertension Society. It's been going on for the past 5-6 years. The latest report was released this morning, and I've already completed the preparation of this for this lecture before then. So in tandem, one of the surveys reported 34.1% of adult Nigerians has been hypertensive. This is to show the significance of hypertension. In addition, there has been an increasing trend of type 2 diabetes among Nigerians aged 20 to 79, rising from 2% in 1990 to 5.7% in 2015. The increasing prevalence of NCDs is alarming, particularly given Nigeria's young population. According to the WHO, by 2030, NCDs are expected to cause more deaths than infectious diseases maternal, neonatal, and nutritional conditions combined. Risk factors for NCDs. This can be categorized into behavioral or lifestyle, environmental, and social economic. The four major groups of diseases as mentioned earlier on constitute 82% of all NCDs. Again, they will cardiovascular disease, cancers, respiratory diseases, and diabetes mellitus. And these four diseases have four main lifestyle-related risk factors. And the factors include cigarette smoking, harmful alcohol use, unhealthy diet, and physical inactivity. They also share four metabolic risk factors, which are hypertension, overweight and obesity, hyperglycemia, and dyslipidemia. These risk factors are all modified. The proportional deaths attributable to each major NCD are communicable diseases as indicated in table 1. And of course, the risk factors and the major NCDs are in that figure 3. The following are the four major behavioral risk factors as mentioned: unhealthy diet, the transition from traditional diets to westernized diets high in sugar, salt, and unhealthy fats has led to the increasing rates of obesity and related diseases. Excess salt intake accounts for 1.8 million annual deaths worldwide. The excess salt intake is derived from the fast and junk food as well as added salt to meals. Physical inactivity, urbanization has resulted in more sedentary lifestyles. Physical inactivity is a major risk factor for cardiovascular diseases. Insufficient physical activity causes 830,000 deaths annually. Tobacco use. Tobacco smoking is responsible for over 8 million deaths every year, including effects of second-hand smoke. Approximately 4.5 million Nigerians use tobacco products. That use tobacco products are affected. Alcohol consumption. Heavy drinking is associated with an elevated risk of liver disease and certain cancers. Environmental and social factors, risk factors, urbanization, socioeconomic status, education. Low health literacy affects health choices, increasing susceptibility to NCDs. The demographic trend. The demographic trend or profile of Nigeria significantly influences the epidemiology of NCDs. With a population exceeding 200 million and a median age of 18 years, Nigeria has a young population that is increasingly adopting lifestyles associated with higher NCDs. Men are more likely to have cardiovascular diseases, while women face higher risks of certain types of cancers. Understanding these demographic trends is crucial for tailoring effective public health intervention. Implications for public health. The rising burden of NCDs presents significant challenges for Nigeria's public health infrastructure. The healthcare system is primarily designed to tackle infectious diseases, but it lacks the necessary resources and frameworks to address NCDs effectively. NCDs will cost developing countries billions of dollars in lost productivity and healthcare costs. In Nigeria, where the economy is already strained, the increasing prevalence of NCDs will hinder economic growth. What are the strategies for prevention and control? Addressing the growing burden of NCDs in Nigeria requires a multifaceted approach. NCDs aggravate poverty by increasing household costs associated with healthcare. Its treatment is often lengthy and expensive, thereby stunting the national economy. NCDs put the 2030 agenda for sustainable development targets at risk, one of which is to reduce the probability of death from any of the four main NCDs between ages 30 and 70 years by one-third by 2030. The WHO recommends various strategies. For instance, recommends 150 to 300 minutes of moderate intensity aerobic physical exercise, or at least 75 to 100 minutes of vigorous intensity aerobic activity. Physical activity contributes to preventing and managing LCDs. Overweight and obesity arise from prolonged hours of sitting, reduced energy expenditure, and increased consumption of junk foods. Targeting the risk factors. Intervention on modifiable risk factors is multi-pronged. Role of government, training healthcare professionals, and integrating NCD management into primary healthcare services. This has just been recently approved, and the document was launched late last year in Abuja. And I was there as one of the experts that drafted that document. Government should provide universal access to primary health care approach as early detection and treatment will reduce costs. The global community needs to drive policies that promote government-wide action against NCDs, particularly stronger anti-tobacco policy, reduction of salt intake and carbonated drinks, reducing alcohol use, and improving people's access to essential health care. This first part of this lecture is about teaching, which I've just concluded. I will now come down to one of the four major diseases, NCD diseases. CVD, that is cardiovascular disease, as a major NCD, and my contributions in this direction. As a cardiologist, my focus has been on understanding the cardiovascular aspects of NCDs. Cardiovascular diseases remain the leading cause of death globally, and addressing this challenge requires a multifaceted approach that includes research, education, and community engagement. By raising awareness about the risk factors, as I've just done in the earlier part of this lecture, and promoting healthy lifestyle choices, we can work towards reducing the prevalence and impact of NCDs. This section highlights some of my research contributions. Epidemiology of cardiovascular diseases. Cardiovascular disease is a major cause of morbidity and mortality, and incidence appears to be increasing globally. One of the major non-invasive investigative tools in cardiology is echocardiography. In an audit of emergency echocardiography in Glasgow, United Kingdom, showed that the test is useful in differentiating an enlarged cardiac volume on X-ray due to ventricular dilatation or pericardial effusion in hemodynamically unstable patients. This was reported in 1993 by OMOTOSHO and al. Our work in echocardiography has also helped in defining the pattern of cardiovascular diseases in our environment. In a study to assess the frequencies of various cardiovascular diseases are diagnosed by echocardiography, hypertensive heart disease occurred in 58.8% and was found to be the commonest cardiovascular risk factor in Ilorin, followed by congenital heart disease in 7.3%, cardiomyopathies in 6.9%, and pericardial diseases in 2.1%, respectively. Ischemic heart disease was diagnosed in only 0.99% of patients. Similarly, the pattern of congenital heart disease and rheumatic valvular heart disease had also been described in our environment. These studies showed that most patients diagnosed with both congenital and rheumatic heart diseases had no opportunity for definitive surgeries because of the prohibitive cost of the procedure. The findings of these studies gingered the management of the University of Ilorin Teaching Hospital to commence an open heart surgical program in order to assist the less privileged patients with structural heart disease. Coronary artery disease is well known to be rare among Black Africans residing in Africa. However, recent reports showed that the incidence of the condition among Black Africans is on the increase due to westernization of our diet, low level of physical activity, and emergence of newer cardiovascular risk factors. A study to assess cases of acute myocardial infarction showed a changing incidence of the condition. By the job of OMOTOSHO, 1998, Kolo Fasha, IV OMOTOSHO, 2013. The incidence of acute myocardial infarction has increased from 0.075% to 0.21% of all hospital admissions. More cases are seen among men. The lower incidence in women may be because women often have atypical symptoms that may lead to misdiagnosis. Mortality rate was 21.4%, and another 21.4% developed left ventricular systolic failure as a complication. Risk factors identified from these studies include excess blood weight, excess body weight, dyslipidemia, that is cholesterol abnormalities, systemic hypertension, diabetes mellitus, and cigarette smoking. This study was followed by another, which highlighted the awareness of heart attack warning signs among the civil servants in Ilorin below modern Saya, OMOTOSHO, 2015. Although 78% of the respondents had heard about heart attacks, only 44% could identify a core symptom, that is chest pain or discomfort. Knowledge of warning symptoms of heart attack was better among women and older subjects. In another study, which looked at coronary artery disease in Nigeria, Isezo Sani Tale OMOTOSHO et al. Consortium in 2021 found the incidence to be 59.1 per 100,000 hospitalized adults per year. For the information of the audience, when we talk of coronary artery disease or ischemic heart disease, we are actually talking of heart attacks. We're saying it is on the increase, even in our locality. Coronary angiography. The coronary angiography rate was 42.4% and only 28.6% are percutaneous coronary intervention, with 11.2% having open heart surgery. Emerging cardiovascular risks. Traditional risk factors were first described in Framingham Heart Study almost 7 decades ago. However, there has been an excess of cardiovascular mortality despite the control of most of the traditional risk factors without cardiovascular events. The result of the study revealed a significantly higher level of homocysteine in hypertensive patients with stroke and myocardial infarction than those without these complications. It was concluded that hyperhomocysteinemia may predict the onset of complications in hypertensive patients. In addition, hyperuricemia and C-reactive protein were found to cluster with traditional cardiovascular risk factors in Black hypertensive patients in our environment. OMOTOSHO et al. Management, the aspect of management of cardiovascular disease, and we look at systemic hypertension. In sub-Saharan Africa, cardiovascular disease has reached near epidemic proportion, and systemic hypertension tops all the risk factors in African patients. However, the surge in cases of hypertension is not matched by clinical trials of antihypertensive medications in Black patients residing in this part of the world. For the first time, we concluded the multi-center, multinational trial of antihypertensive medications in hypertensive patients born and living in sub-Saharan Africa. The trial tagged newer versus older antihypertensive agents in African hypertensive patients, that is the NOAH study, was sponsored by the University of Kinshasa, Democratic Republic of Congo, with support from Novartis Pharma, and was coordinated by the Division of Hypertension and Cardiac Rehabilitation, University of Leuven, Belgium. 6 centers in Africa, including our center here in Ilorin, recruited patients for this study. To our knowledge, NOAH was the first successful of such randomized clinical trials of antihypertensive treatment in sub-Saharan West Africa. OMOTOSHO and DON 1992 revealed that the reversal of left ventricular hypertrophy, that is thickening of left ventricle, is associated with improvement of left ventricular function, especially gastric function. Furthermore, in an open label study in the control of hypertension, OMOTOSHO prodigy and rotational 1997 demonstrated the effectiveness of 2 reserpine-containing antihypertensives, reserpine clotariban for the older patients, and you remember the proton, and versus reserpine dihydrocristine / dopamine. Again, the older patients will remember grenadine in those days. Severe elevation will demonstrated the efficacy of these medications. And however, these drugs are no longer in routine use because of the side effects of reserpine. Severe elevation of blood pressure is associated with target organ damage, and as such, parenteral medications are used to bring the blood pressure down. However, some of the parenteral agents, such as hydralazine, may lead to precipitous fall in blood pressure. Okoro OMOTOSHO 1986 studied the use of oral labetalol for urgent treatment of severe hypertension. Labetalol was found to be effective, and the drug is still used today for management of hypertensive emergencies. Similarly, Arijan OMOTOSHO 1994 studied oral slow-release nifedipine. Patients here will easily identify with Nifecard XL, Nifecard, Retard, and all those things. Nifedipine, which was found effective for the control of severe hypertension in Nigerians. This drug is still being used for the control of severe hypertension, especially the plain nifedipine. Hypertension and diabetes coexist. I describe them as siblings in Nigerians with metabolic syndrome. The combination of these metabolic abnormalities often leads to endothelial dysfunction and insulin resistance, is associated with increased risk of major adverse cardiac events. Microalbuminuria has also been shown to be a predictor of excess cardiovascular mortality in hypertensive patients compared with the normal healthy controls. The occurrence of lower levels of arterial blood pressure has been described in sickle cell anemia patients. AYODELE OMOTOSHO et al. In 1998. We suggested the role, for the first time, we suggested the role of nitric oxide to account for this finding in sickle cell anemia. Other factors have been implicated by other workers, which include body mass index, body surface area, hematocrit, and frequency of crisis. Heart failure. Heart failure is the final common pathway for most cardiovascular diseases. Early diagnosis of heart failure is key to the management of the condition. Heart failure essentially remains a clinical diagnosis. For objective assessment of heart failure patients, echocardiography is important. Initially, the place of echocardiographic assessment of patients with heart failure was controversial, especially in resource-poor settings. We clearly defined the role of this investigative tool in management of this condition. OMOTOSHO 2010. Echocardiography was found to be cost-effective in heart failure management because it can differentiate systolic from diastolic failure, and findings from the test may lead to initiation of life-saving medications. It can also be used to exclude other cardiovascular conditions that have similar presentation to heart failure. The role of electrocardiography has been explored in the diagnosis of heart failure. Electrocardiogram is an old tool used in initial assessment, diagnosis, and subsequent management of heart failure. In a study by BABATUNDE and OMOTOSHO in the year 2000, we demonstrated that ECG alone lacks sensitivity and specificity in the diagnosis of heart failure. However, a combination of detailed history, focused clinical examination, test radiograph, and ECG improves the diagnosis of heart failure. Heart failure has continued to be associated without mortality profile, despite discovery of innovative medications that improve the outcome in the patients. 5-year survival of heart failure patients in New York Heart Association class 3 and class 4 is still greater than 50%, which shows the burden of heart failure. The assessment of hypertensive heart failure outcome among Nigerian and Gambian patients showed a 1-year survival rate of 71%. In other words, from diagnosis to end of the first year of diagnosis, 19% of the patients will have died. That's 29%. 29% of the patients will have died. It says OMOTOSHO about 2000. Some of the prognostic factors causing high mortality among our patients included late presentation by the patients, prolonged QTc interval, hyponatremia, low left ventricular ejection fraction, and racial differences. One of the causes of heart failure in our environment is dilated cardiomyopathy. The etiology of this condition may be idiopathic, that is, it may be of unknown etiology, but viral and genetic alcohol and toxins have been implicated. In a study, we found excess HIV cell positivity in patients with dilated cardiomyopathy compared with other causes of heart failure, implicating that virus in the etiology of dilated cardiomyopathy. We reported this OMOTOSHO around the year 2000. Cardiac arrhythmias, just like you have electric power supply, NEPA supply, the electrical conduction system in the heart will also have arrhythmias. We call that cardiac arrhythmias. And they are a major cause of morbidity and mortality as complications of many cardiac diseases. The regulation of autonomic nervous tone plays an important role in the development of cardiac arrhythmias. In patients with cardiac diseases, heart rate variability and index of autonomic nervous tone is assessed in patients with heart diseases to determine their risk of developing cardiac arrhythmias. In the NOAA study, antihypertensive drugs were found to modulate heart rate variability in native Black Africans, and we reported this in 2013. This has implications for choice of antihypertensive medications. Cardiac arrhythmias associated with hypertensive heart disease increase the risk of sudden unexpected cardiac death in the patients. In a study of 2017 Nigerians with hypertensive heart disease, OMOTOSHO around 1997 demonstrated increased risk of cardiac arrhythmias, the commonest form being premature ventricular contractions. High-grade arrhythmias are low due to rarity of ischemic heart disease in our environment. Prevalence of atrial fibrillation increases with age, even though it is still low as reported earlier. In the same vein, in another study, we found an increased risk of dangerous cardiac arrhythmias such as PVCs, atrial fibrillation, and paroxysmal atrial tachycardia in hypertensive patients with intraventricular conduction. In addition, children with sickle cell anemia are at an increased risk of cardiac arrhythmias, causing myocardial ischemia or infarction, especially in the tropics. In a study by Bode Thomas of and OMOTOSHO in 2003, sickle cell anemia patients appear to be more prone to cardiac arrhythmias than others. Similarly, the same group demonstrated prolongation of QTc interval in Nigerian children with sickle cell anemia, and this is a risk factor for cardiac arrhythmias. How about the subject stroke? Stroke remains one of the major causes of mortality globally, and low and middle income countries account for over 87% disability adjusted life years from stroke. In advanced countries, stroke is a disease of those 65 years and older, but the majority of our patients are younger than 65 years. Cardiovascular complications, we also looked at this subject and made some findings as stated in the slides. Cardiovascular prevention, children of people with systemic hypertension are thought to be at an increased risk of developing hypertension and cardiovascular complications, and we have studies in that direction. That is for research, and that was why the language was a bit technical. We now move on to community service. I have had the privilege to serve the University of Ilorin, that is service to the University of Ilorin. I've had the privilege to serve the University of Ilorin in many and diverse capacities. This includes but not limited to the following: training. I have had input to the training of all the 4,932 medical doctors so far produced by our College of Sciences in the University of Ilorin from 1983 to date. The first 3 years were, however, as a pro bono associate. The long period of service has afforded me the opportunity to teach children of my former students in this college. Administrative work. I've had a long-standing commitment to the University of Ilorin through various routes. I was a member of the University of Ilorin Strategic Plan Implementation Committee. Professor Bayo Lawal is here. I think he anchored that particular document when he reviewed this. I was a member of the University of Ilorin Governing Council for 8 years, where I served on the Finance and General Purposes Committee and represented Council Appointments and Positions Committee from 2018 to 2023, the position I earlier held between 2010 and 2014 as representative of Senate on Appointments and Promotions Committee. From 2010 to 2014, I was provost of the College of Health Sciences. I chaired the Committee of Provost and University. I chaired the Board of School of Preliminary Studies, the College of Health Sciences Academic Board, and the College of Health Sciences Admission Committee. I was the first substantive dean after the first acting dean, Professor B.J. Mojiwo of the Faculty of Clinical Sciences, when the collegiate system was attained. Again, I also acted as dean in 2020 to 2021 during the COVID pandemic. I chaired or participated in numerous ad hoc committees of the Senate and Vice Chancellor's House Committee, 2006 to 2014. Worthy of note was my membership on the committee that restored and repackaged the Inuagural anthem in 2011. Whenever you sing the anthem, as you have done at today's inaugural lecture, this reflects on the heartfelt efforts of the committee. In the same way, I was acting chairman of Ilorin Interreligious Council between 2004 and 2007. And I've earlier served as sub-dean of the Board Faculty of Health Sciences between 2000 and 2003 and Health Department of Medicine 2002 to 2006. Some innovations that I will just itemize in this segment is the introduction of the OSCE-style clinical examination into our program in the college, the introduction of problem-based learning as a mode of learning, establishment of the clinical skills and simulation laboratory shown in figure 4 of this presentation. And what you have here was as a result of collaboration between our college and the University of Cape Coast Ghana. Introduction of the curriculum innovations such as introduction of curriculum innovations such as expanding the academic aspects of COGI's program. And I thank Professor T.M. Akande, who headed the committee in 2008 that set up to look at this aspect. We also proposed and designed a college auditorium, which we thought the college would be able to fund by listening with powerful politicians in the state. We have that, we have the drawing in figure 5A and 5B. Unfortunately, we could not actualize this project because we were disappointed at the last minute. I have deliberately put it here, Mr. Vice Chancellor, sir, so that you can take it. They look at it. We did everything, including the beekeeping. Quantity, we call it, everything is money. And it will have cost us just 200 million in 2013. I don't know how much it will cost now. But that's the diagram. And I've sought permission on the provost to keep that picture of them. Service to the UITH. I began as its chief resident in the Department of Medicine in 1985, became honorary consultant in 1987, was a member of the UITH Managing Board and top management committee from 1994 to 1998, and also 2010 to 2014, and served as head of the Department of Medicine 2002 to 2006. My leadership extended up to serving on various committees, including being chairman of Medical Advisory Committee, Finance and General Purposes Committee of the UITH, Appointments, Promotion and Disciplinary Committees, Board Tenders Committee, Staff Welfare Committee, and Manpower Development Committee. Additionally, I chaired all the revolving fund schemes as at that time from 1994 to 1998. Service at the state level, I've contributed to various aspects at the state level in Kwara and other states. For instance, I was on the visitation panel to the State University Teaching Hospital in 2018. National assignments. Nationally, I've served in numerous capacities, including as a member of NACOM and the chairman of its education committee, 2010 to 2020. I've been an external examiner for various universities across Nigeria and participated in various NUC meetings on medical education. My roles extended to chairing NUC accreditation, that is the medical panel exercises on the universities. I've served the Medical and Dental Council of Nigeria on various accreditation panels. On the international scene, the details are as projected. On the international scene, I have been examiner, chief examiner, internal assessor, college vice president, and chairman of the Nigerian chapter of the West African College Physicians, and chairman of regional forums in the West African Health Organization. I have been president, Nigerian Hypertension Society, and under my watch, we produced the last treatment guidelines for hypertension in Nigeria. For community service, my community service includes being chairman of the board of directors of Mayo Healthcare Limited, an Ilorin-based HM organization, and also includes holding the traditional title of Ogbonwan in Nigeria. Our membership in various community associations. I have served as director of music and organist at the Chapel of Light University of Kenya in 1985 to vote. This year marks 40 years in that capacity. Vice Chancellor, sir, my recommendations. Distinguished ladies and gentlemen, I'm optimistic that the following recommendations will be useful to the university, government, and other stakeholders as we continue to care for the heart. For the university, we should enhance research and development. We should encourage interdisciplinary cooperation. We should have, as a policy, community engagement. We should also look at curriculum integration, integrating SCD-related topics into the curriculum across various disciplines to ensure that students are well informed about these diseases. The College of Health Sciences should resuscitate the periodic university-wide public lecture an interactive session on NCDs and other health-related matters. And we are doing this before. We are doing this before. The university should institutionalize compulsory annual medical checkup for all members of staff for early detection and treatment of NCDs. The government policy implementation, all policies that have been formulated should be followed through. The government should make healthcare accessible and affordable to patients. Public awareness campaigns should continue, and funding and provision of resources should also continue. Government should fund and equip and support at least one tertiary health facility that can take care of complicated CVDs in each geopolitical zone. For other stakeholders, the private sector should be involved, NGOs, international collaborations, and we should leverage on technology and innovation. Conclusion, Mr. Vice Chancellor. Mr. Vice Chancellor and distinguished ladies and gentlemen, as I stand at the threshold of a new chapter in my life, I'm filled with a profound sense of gratitude and fulfillment. The journey of the past 4 decades has been one of relentless pursuit of knowledge, unwavering dedication to the field of radiology, and a deep commitment to improving the lives of those affected by non-communicable diseases. Throughout this journey, I've been privileged to work alongside brilliant colleagues, passionate students, and supportive institutions. Together, we have made significant strides in understanding and addressing the complexities of NCDs. Our collective efforts have not only advanced scientific knowledge, but also brought about tangible improvements in patient care. As I reflect on the title of this lecture,